data, and then also it'll allow you to write in some information there. So I just wanted to briefly go over that, and then kind of just ask you, I know last time one of our follow-ups was essentially you were going to go and I guess speak to some of the other vascular surgeons and see if there's any, I guess, requirements, or just kind of gather requirements yourself as to what you would want to see, because we do certainly have the option of adding, you know, a new type of auto text like this that could be specific for you. We can even make it specific for VGH as well. So for example, we could literally just recycle this auto text title, but then put like VGH VA, something like that. And so that would essentially be your auto text that you would use, and it could be customized specifically for your site, essentially, or for yourself. So that's kind of an option we can have. So I just kind of wanted to bring it up to you and see if you had time to gather any of those requirements, or just if you have any thoughts in general about that.
Yeah, absolutely. So I have been able to speak to the other surgeons. I think the note you have on the right-hand side of the screen now is actually quite good. I think it has a lot of the key points. One theme that I've heard a few times is that we don't want these notes to be overly complicated. These dialysis patients have very long medical histories. One thing I've noticed at Lionsgate when we're using this is that it tends to pull in way too much data. So you end up with a note that's diluted by the fact it's trying to incorporate the entire patient's history. So I think we want to keep this quite simple. Now, I'm just wondering, so the patient's GFR would that be brought into the note automatically from from Cerner, or would that be something we type in?
Yes, it would. Now, team, correct me if I'm wrong, but I'm almost certain that it does actually pull in the most recent results that are documented in Cerner.
Okay, perfect. And then for the vascular access history, would it pull in the previous operative notes, or would that be something we would have to type in or dictate ourselves?
Yeah, that's a good question. So I know it does pull in some information. Maybe if there's anyone on the PET team that can fill in. I don't remember exactly where it pulls from, but I believe it does pull in some information that's populated. But I'll leave that maybe to the PET team if someone knows for sure what it does pull in.
DD, maybe correct me, but I'm just looking at the auto text right now, and I think the EGFR and the vascular access history are actually manual. So you'd have to insert that information yourself.
Is there a way to have, I just remember at Lionsgate, for example, if I use the general surgery consult, if I selected that note, then it will pre-populate my own note with a ton of information that's kind of collected from the emergency physician's note, et cetera. And my concern with that is it becomes very complicated. So for example, using that Lionsgate example, for their general surgery consult where it says chief complaint, it'll have, like 2 or 3 sentences that are written down from the triage emerge nurse. So I just want to kind of get a good understanding from you guys, what information will be kind of filled in to the note when we click on it.
Right. So I don't know, Brian, do you think it would be easier to just kind of show what you have in the back end? Is it kind of user friendly for Dr. Poles to kind of see what pulls in, or?
I can demonstrate on a test patient, but just at a high level, any information that is documented on that encounter by any clinician would pull into the note based on the kind of headers that are on the current note that you're using. So if multiple people documented a chief complaint on that single encounter, then you're correct, it would pull in to a note that you're creating. And the workaround for that is basically deleting that information yourself if you don't think it's relevant when you're signing a note.
Well, that's the trouble is,
right.
So for example, for a dialysis patient, they may have had an emergency department visit. They've been seen in dialysis, so they're going to have numerous visits with different chief complaints, I imagine. So I don't really think that's relevant or probably more harmful to have that pre-populated. For our note, all we'd want to say is, they're either going to present with a concern about low flow on dialysis or arm swelling or need for new hemodialysis access. So I think that's what we want to see pre-populated, not that the patient presented with chest pain to the emergency department on February 17th or something. Do you understand what I'm saying?
Yeah, definitely. So the way the functionality is built is that chief complaint and some other data that's pulled in is based off the current encounter. So I think what I'm hearing is it might be better for you guys to have a custom template that doesn't have these automatic pull-ins, because you're being pretty simple with the information that you're inserting. So we could create a new template that's very specified to that. And if there is anything that you want to pull in automatically, we can kind of explore that as we go. Does that sound like a better
for
solution?
example, yeah, I think it does. Ideally, what I would suggest is to have a chief complaint, which would have one of three options. It would be patient presenting for assessment for new hemodialysis access. The second choice would be patient presenting with new arm symptoms, or 3, patient presenting with difficulties with current fistula. Like if you have one of those, you could pick one of those 3. That would really simplify the note for us. So the reason for referral would essentially be one of those 3 things, or the surgeon could dictate something differently. But those 3 things would be the main, would probably capture 90% of the patients we see.
Yeah, so the functionality that would achieve that is we have the option of including dropdowns. So we could pre-populate a dropdown with those 3 options, so that any of the clinicians that are using your auto text don't have to manually type those in. They would just click the drop-down arrow and select one of the 3. And then they still have the option of free texting in if it's not one of those 3, the 10% scenario that you mentioned.
Okay, I think that would be good and then for the referral from, ideally that could be pre-populated either from Cerner directly, or if Sophia or Thomas could enter that. The most recent GFR would be helpful if that could come directly from the computer without anyone having to enter it. And then the current access, if any, we could either have a drop-down box, which would say radiocephalic fistula, brachiocephalic fistula, brachiobasilic fistula, or central vein catheter. I think if we had a drop-down box with those options in it, that would really simplify things. Dominant arm could also be pre-populated before we get to clinic. So sorry, just where you're typing there, who's ever typing, I'd say fistula type or catheter. Yeah, that's perfect.
Sorry, can I just go back to the eGFR for a moment? Sometimes it may be a period of time. So there may be an old eGFR. So the question is, how far back do you want the system to look for a last value?
I would just say most recent GFR, irrespective of how long back it is, as long as it's dated, even if it's from 2 years ago. I mean, it's just, that's the most recent one. That's what we're working on. It won't be, but I would just say the most recent GFR, doesn't really matter how long. And you'll see with these patients, their GFR will be done within a few weeks or a few months. It's really rare that we wouldn't have that information.
Now, actually, regarding that, where is the data? Is the data from Life Labs going to be automatically dumped into Cerner? Because most of the patients will have the GFRs done in Life Labs, not in the hospital system lab.
Yeah, so those external labs will be in the system as well.
Oh, okay, great.
Yeah, there are, I will say there are certain exceptions. For example, like labs in Yukon, I believe, aren't configured to pop in certain like extremely remote areas throughout BC. But I think it's like, at least 95% or more coverage in terms of those external labs.
Okay, that's great.
Looking at your form for physical exam, I would probably, the question I had is, Thomas, do we do vital signs in these patients normally?
I do blood pressures just for comparison between the 2 arms to see inflow problem.
So, and then Thomas, are you going to, do you see the patients a day before typically, or a few days before?
It varies. It could be just the same day before clinic. It could be any time before then. It could be a week before sometimes.
It'd just be useful to have that information that you've already collected populated into the note if possible. And then for the ultrasound assessment, I think that would be something we would just dictate. I don't think a drop-down box would be useful there. It would just be something we would dictate into the system ourselves. The other
Yeah,
relevant.
I believe that one is just a free text box.
Okay.
Correct me if I'm wrong, Pat, but I think, yeah, usually those assessment ones are kind of like just free text for you to write in.
And was it for other relevant investigations, what we would be interested in is any studies done in radiology. So for example, a CT scan, a fistulogram, or vascular lab studies or finger pressures would be the stuff that we'd be most interested in. Is it possible to have those included under other relevant investigations?
Are you wanting like the results, or are you just wanting to know if they were done?
Good question. I think it actually would be useful to have the impression in the plant, or the radiologist's final impression. So if they had a fistulogram, they'll dictate an entire report. I'm not sure it's important to have the entire report in the relevant investigations, but are you guys able to just have the last paragraph from the radiologist where they write kind of their final impression?
I don't know that that's something that's feasible.
Okay.
But we can certainly look.
Yeah, it's a good question, because we don't want to have, 3 or 4 full reports, because each report would be a few pages long. So I guess for other relevant investigations, if we're unable to just have the final impression and plan included in the note, then just to have a list of maybe the most recent relevant investigations done over the last 3 months. So then at least we know. Sorry,
what I know is possible though is that you can open up reports and then you could tag the information, which is very similar to copy and paste.
Okay. You'd have to show me how to do that. I'm sure there'd be some more training for this, but yeah, if there's a way to do that, it'd be useful.
Yeah, no, I think that's a good thought, and you'll certainly have plenty of time throughout your adoption training to play around with all those reports and look at how to kind of gather information like that. Okay, so I think this is a great start. I think there's certainly, some of these aspects are quite easy for us to just build out in the system. For example, something like chief of complaint, we can easily add a drop down that just has these options, stuff like that. Any other things that you're, I guess, seeing that you'd want to include in this? Any other comments at this point, Dr. Fold?
Yeah, I think the other one we're missing is, so we have vascular access history. No, that'd be fine. So for that box, it would be useful to have, all of the previous operations listed if possible, because that would be something we want to know. For example, you'd want to say that, January 15th, 2018, patient had a radiocephalic fistula. And then, September 2021, the patient had a brachiobasilic fistula or something, so if that would be possible to bring in. The way I get that information now is we go to PCIS, we go to patient-specific dictations and look for operative reports, and then just identify any operative reports by vascular surgeons. So if it'd be possible to include it, that'd be great. If not, we'd just have to scan the patient's charts for operative reports, as we're doing now.
Right, and so you're talking about specifically for like vascular cases, right? I know we have certain other components, like for example, procedure history that would just pull in like recent surgical cases, but you want something more specific.
Well, what we look at is, what I look at is any operative reports by a vascular surgeon. Some of these patients will have had 5 or 6 previous attempts at vascular access, so that that information is quite important to us. If it's not possible to pull that in, then we'll just have to look ourselves. The difficulty with these patients is that they tend to have numerous comorbidities and numerous procedures. So I don't necessarily need to know whether they've had a general surgery operation or they've had a parathyroidectomy or all this other, I don't need to know every operation they've necessarily had, but I would be quite interested in what previous vascular surgery they've had.
No, I think that's definitely something we can look into, and I'm sure we can solution something similar to that. So I'll note that down. Any other aspects of this kind of example auto text that you would want to see, I guess, improved upon? Anything added? Anything removed? Actually, is something else that's worth asking.
I don't think so. I actually think it looks quite good. Thomas, do you have any suggestions?
No, it looks okay. I guess we're probably working still on the details. For the chief complaints, I kind of looking at sort of the clinic, and I think what we do quite as frequently is a simple maturation assessment. So that's some of the quite common often, the menu is a maturation assessment really, and post-op assessments as a reason for, but the rest, I guess it's kind of, yes, same.
Okay, so just to summarize then, so we'll add maturation assessment into the drop-down box. And then just thinking about it here, where it says most recent GFR, I would also have a tab saying most recent INR. That's something we, actually never mind, because most patients will be on 10A inhibitors, so that's not going to be useful.
Okay, so no most recent INR. And sorry, that additional drop-down, were you meaning to add that to the chief of complaint?
Sorry, I can't see it. Yes.
Sorry, that's quite small. And sorry, could you just repeat what that was again? That
maturation assessment.
Perfect. Okay, that's great. Okay, so I think this is a good start.
And post-operative assessment?
To the chief of complaint as well?
Yeah, another option on the drop-down menu.
Would that not be the same as maturation assessment, Thomas?
I suppose we could fit it in there.
Yeah, just leave it as that. I don't want to make this, we don't want this too complicated.
Sure.
Okay, but you prefer this to be the title, maturation assessment. We don't need to mention post-operative.
Thank you. Yeah.
Okay, perfect. Okay, so I think that's a good start. I think in the interest of time, it might be good to move on, unless there's anything else that comes to mind. Keep in mind, Dr. Foles and Tomas as well, if you guys kind of have any more ideas, any more thoughts, feel free to just email me. What I can do is after this session, I can just email this list that we have, maybe just email the screenshot of what's existing, and you can kind of use that. Even Dr. Foles, if you wanted to kind of bring that to some other vascular surgeons and discuss, feel free to do that as well, and keep us posted. So it sounds like what we'll look at doing is essentially investigate if we can kind of, satisfy the needs of this additional functionality, and potentially build out a separate auto text that would say something like, I don't know, VGH renal VA clinic note, something like that, something that is specific to VGH, and that would have these kind of adjustments, just so the regular, renal VA clinic note would still be available for other users as well. Does that sound good to you guys?
Sounds perfect. Thank you.
Awesome. Thank you for that. This is very helpful. Okay, so I think we'll move on now. Unless, sorry, I should probably ask from our pet side. Brian, was there anything else you wanted to show or anything else you wanted to kind of add to this portion?
I think just maybe a little bit of clarity on that existing screenshot on the right there. Are there any of those sections that we are going to remove? Like, is the ultrasound assessment relevant, and I guess maybe some of the other
I would keep all of that. I think everything that is in that form is good and concise. For the ultrasound assessment, we'll either dictate that ourselves, or if we could, I guess the other question is, if we talked about this last time, how Thomas has the drawing that he does. If it's possible to have a link to that, so where ultrasound assessment is, if there was some way to link to Thomas's drawing that we could just click on, and that would be quite nice. I'm not sure if that's possible or what we ended up deciding for that.
Is that the vein
So that's
mapping?
certainly,
That's
yeah, so
correct.
that's a good transition into the next portion. We're going to be talking a little bit about that whole vein mapping portion. I don't know if there's a way, I don't think there's a way for us to kind of build that into this auto text. Correct me if I'm wrong, Brian, but I don't believe that would be, especially because essentially this is an image, you know, that Tomas marks up with actual information. So the only real way to get it into the system and have it be easily viewable by you, Dr. Folds, is to scan it in through WorkHumana and then associate the patient's chart. So basically it turns into kind of a scanned PDF that's on the patient's chart, and you're able to find it. I'm going to go through how you would actually locate that information. But again, I don't think it would be something that we could actually kind of pull into the auto text. It would be a separate piece of documentation. One option that you could do, for example, is within the auto text that you're writing, there's opportunities, there's some areas where you can write free text, and you could even just, you know, put a little note saying like, you know, this is relating to the vein mapping document from this date, something like that. There's kind of some operational, I guess, strategies that you guys can come up with just to link those two pieces of documentation. But I don't believe there's an actual surefire way to do it in Cerner in terms of what you're asking about. But please, once again, Brian, correct me if I'm wrong.
No, what you said is correct there. We're going to have it as a scanned document.
Okay. Does that sound okay, Dr. Folds? We can kind of brainstorm on some ways to, I guess, point attention to that document and link them in some ways in terms of like free text, something like that.
No, I think that's fine. Thank you.
Okay, awesome. Okay, great. So we basically agreed to keep the current sections. Sounds like essentially we want to add some additional content. So we'll do some investigation, see what's possible, and then we will kind of come back. We have another session scheduled in April. So I think what we'll do is we'll probably just dedicate a nice portion of that session to this content, and we can essentially show you a prototype version of this with these updates, and we can go through it again with you, Dr. Folds. And if you have any additional comments, then we can take that back and kind of review it. But like I said, I'll send this to you. So I think that would be helpful if over the next, you know, month or so, if you could kind of float these ideas by other vascular surgeons and maybe just kind of brainstorm on it yourself and bring back anything else to the next session.
Yeah, it sounds wonderful. Thank you.
Excellent. Okay, so let's move on now to our vein mapping document. So the team kind of thought about different strategies on doing this, and I think we kind of touched on it in the last session. Essentially, it is that original idea we had. So I'm just going to quickly go through how you would actually do this workflow. It's kind of a collaborative workflow. So Tomas and Sophia, you guys would handle kind of the earlier portion. So basically, there'd be this paper form, which Tomas would mark up. That would be faxed into WorkHumana, into your specific VGH renal vascular access queue. Then that document would be associated to the patient's chart. I think we did demo this in the first session, but I'm just going to quickly demo it again because you guys might have forgotten by now. So this can be done by either Tomas or Sophia, because the nurse position that's used in this area does have access to WQM. So Sophia, you'll essentially be doing this already for other referrals, other files that come in through WorkHumana. So I think it makes sense for you to kind of be the point person that would do this process as well. But Tomas, you do also have the ability to do it. And I know you guys work really closely together, so it can kind of be, you know, teamwork in that sense. So I'll kind of show how that works, and then we'll go into PowerChart and show how to actually view that document. Before I do that, I quickly did want to ask, because I know there's this other page that also is kind of goes hand in hand with this document. Would this page be necessary to be kind of preserved with this markup as well, Tomas? Like, would we always want to kind of fax both of these as one document into Cerner? Or do you sometimes just use the picture portion of this form?
I really more keep the arm for the mapping, the vein mapping document. We kind of keep that. The second one, this one is really, we don't keep that form. This is just simple, sort of like a little notepad during doing the actual assessments of the patient in the clinic, and that gets actually discarded. So that doesn't have to be really kept.
Oh, okay, that's good to hear. And Dr. Folds, just to confirm, so you don't really utilize this form. It's mostly this one that Tomas marks up that you utilize, correct?
Absolutely. Yep.
Excellent. That's great to know. That makes this a little bit easier to deal with, so that's good. Okay, so we'll hop right into the system and show this. So I'm not sure if you guys remember, this is Work-Queue Monitor, how it's laid out. I'll just do a quick review again. So each of these tabs kind of represents a different facts line, if you will. So we already decided that yours won't follow this naming convention. It's going to be VGH Renal VA. So that would be what your tab title will be called, and that's where documents would come through when they're faxed into your clinic. So for this workflow to work, what we essentially would do is after you'd fill out, mark up that form, Tomas, either you or Sophia would fax that form into, using this number, into your own clinic. And that would essentially digitize it and preserve it in this sense. I know this is not what it actually, but just imagine that this is your nice vein drawing here. So then it would come into Work-Queue Monitor as a work item. And basically it would just appear as a row like this without much information labeled on it at all. So once you see it, you would just double click, that would open it up. And the first thing we're going to do is find the correct patient to associate it to. And obviously in this case, you know, you'll be working with that patient, so you'll kind of know which patient to look up. So we just do this search patient here. I'm just going to use a demo patient. I'm actually going to use our HD demo patient just because they have some other documents I want to show, but you can filter that later in PowerChart. So it's always best to do this as the first step, just because then the patient information populates in this banner bar. So you just know that you are selecting the correct patient. In this case, the patient only had one encounter. It was just a recurring encounter. In this situation, we're just assuming this patient's already on hemodialysis, and for whatever reason, you're kind of reassessing this information. So if they did have multiple encounters, though, this is where it'd be really important to select the right encounter, especially if you're doing this, Tomas, because I think typically selecting the correct encounter is kind of something only clerks really have to be concerned about, because for the most part, the correct encounter is associated with the case by the time a nurse or physician sees the patient in the system. So that would just be kind of a learning point for you, Tomas, if you were doing this workflow, is just be really careful about which encounter you select, making sure it's the correct one. So once we've selected that, we'll use this document type field here. So this is kind of what is going to label the document in the correct way for us to be able to find it easily later. So we're just going to go, we're kind of discussing what document type would be best to use for this. So far in the system, the one that seems to be the most relevant would be this vascular diagnostic report document type. So basically, once you press OK, it'll populate this document type, and this is going to pull into PowerChart later. It'll kind of appear as this document type. So Dr. Folds will kind of know this and utilize this to search up, to be able to filter and find this document easily in the system. There is a shortcut to this. There's kind of like a numerical code for each document type. So if you want to like save time, you can just remember, okay, that was the wrong code. But basically you would just remember, and then you type in that number and it would show that document nice and quick. But I'm just gonna go back, select it here, 8204. So that would be the code. If you just type in that code, it'll populate quickly here. So there's not much more I'm going to fill out here. I think the only thing I'm really gonna do now is just complete this document. And yeah, I think that's enough. So once you fill in those fields, you'll just press OK. And what that's going to do is it's going to associate that document to the patient's chart, and it disappears completely. So you essentially can't get it back into this Work-Queue Monitor unless you refax it in. So that's why it's so important to make sure you're selecting the correct patient in that process, because once again, you kind of have to restart the workflow if you do get the wrong patient. And not only that, it becomes a little bit laborious to go and in-error the document on a different patient's chart. So that's just important. That's why I was kind of emphasizing that whole encounter strategy. So that's basically the end of what Tomas, either you or Sophia would do to process that document. So once that's done, now we're switching to Dr. Folds now. So basically, right now I'm just in PowerChart. I have that patient opened up, and right now we're just on the quick orders landing page. So Dr. Folds, you would essentially go to this outpatient chart tab here. That's kind of your main, I guess, workflow end page. And then you go down to this document section here, this component. So in this component, this is where various document types will appear. So if I refresh this, I'm going to see some documents pull through. There's various filters here that you can use to kind of refine the results. So if I select this vascular surgery documentation filter, and it looks like it's not going to appear. So this is kind of where we need to do a little bit of back-end work, because basically what we want to do is just ensure that that document type that you select earlier in Work to Monitor will then pull in that document here. So I know right now in our build domain, it's not set up that way, but location is wrong. Yeah, that could be it. But basically you can play around with these filters and you can select different ones. So before we saw that provider documentation filter was selected, so it pulls in documents here. It's relatively easy to kind of cycle through the documents. For example, that document that we just pulled in, it would have the date of today. So you can kind of use this last updated field here. If you just click the column, it'll sort the documents. So it'll show like the most recent document that was uploaded. So that's one way you can find the document. You can also kind of sort through the note type fields here. Any of these fields, you can just click them and it'll reorganize the documents. So this should be a relatively easy way to filter the document. I know it didn't actually pull through here, but it's just because we need to kind of configure it that way. But again, for you, Dr. Foltz, it would be relatively quick. You would just literally go into outpatient chart, go into documents here, and then kind of play around with the filters to be able to find that document that it pulled through. We can actually look at it now just so you can see that it did go through. If we go to this documentation.
So just a couple of questions about that, Jesse. First of all, at Lionsgate, I believe the default is all physicians' documents. So when I go to look at a patient's chart and click on documents, now normally that's an inpatient chart, but then all physician documents would be available. So I can read an emerge docs consult, the nephrology consult, all that sort of thing. Will that be the default screen, or will it just be outpatient notes? Like what is a default screen? And then the second question is, would we be able to access the nursing documents from dialysis? Because sometimes we have questions about the how their last dialysis session went, for example, what the pressures on the machine were, that sort of thing. So are we able to switch between all physician documents, the vascular surgery specific documents, and then review some nursing documents if we find that necessary?
So yeah, great question. So here, I believe your default filter will be this provider documentation one. I do wonder though, as the vascular surgeon, it's possible your default filter will actually be this vascular surgery documentation.
And that's fine.
Yeah,
I think that's totally fine if that's a default one.
Okay. Yeah, so it looks like it will be the provider documentation. So that'll be your default kind of filter. Obviously, as you see, it's pretty easy to just click change filter and then you can change it. So your question about nursing allied health documentation. So there is this nursing filter here as well. So basically you can just add that. You can have both filters. You can remove the provider one if you just want to see nursing. This patient doesn't have a lot of documentation, so it won't really be useful to like cycle through different documentation types. But of course, an actual patient in the live domain will have lots of documentation types. So yeah, if you utilize these filters, you would be able to just see nursing documentation. You could turn that off, go back to specifically vascular surgeon documentation. And then if you wanted to, again, just use provider documentation, then you'd be able to see like other nephrologist documentation that might be pertinent to you as well. And I believe this would also pull in like the vascular surgery documentation. It would just pull in all documentation from providers.
Okay, well, that's great, thanks.
And so these filter types that you see on the screen, like you think that those are kind of the main ones you would use, I guess, that you brought up, right? The specific vascular surgery documentation, overall provider documentation, and then just the nursing documentation.
Yeah, no, if there's a way to have the nursing documentation kind of pared down further to just dialysis unit nursing documentation, I'm not sure if that exists. If it did, that'd be helpful. If not, then it's no problem.
Good question. I mean, so you can group documentation by encounter. So for example, you could select, in this case, the recurring hemodialysis encounter, and that would only pull in nursing document types that are linked to that specific encounter with the patient on dialysis. So I think that would probably like satisfy that requirement if you're specifically looking just for the patient's like dialysis documentation. If you were on that recurring encounter, should they be using that recurring encounter throughout their whole HC treatment? That would effectively kind of limit it to just seeing, you know, nursing documentation on this specific encounter. So that might be, I think that would kind of satisfy what you were asking there. Does that make sense?
It does. Thank you.
And another thing I should mention as well, as there's some other things you can look at for information like that as well. So obviously what we were focusing on was documentation specifically, right? Like in terms of note types, et cetera. You can also go to results review, and this will allow you to kind of look at previous documentation that the nurses have made, you know, hemodialysis or even related to some of the access information that we're looking at. So if you go to this dialysis view here, it'll actually pull in, you know, documentation that was made in iView, for example, specific to their dialysis. I don't think this patient has much access documentation here, but if they did have, you know, access related documentation like AVF type, et cetera, those data points would pull in here as well. So that's kind of another way to view just some of the other documentation that nurses make that's more specific to these kind of fields, which we call VTAs. And it's relatively flexible here too. You know, you can look at different lab work. You can also modify the actual like date range as well. So you can look really far back if you wanted to look at some historical trends, et cetera. So yeah, the results review functionality is quite flexible just in terms of looking back and finding previously documented information.
Okay, thank you.
Problem. Any other questions just about what we just went over with this document type? I think we will have to go back and just kind of find the best way to connect that document type when it's processed in Work-Q Monitor and just make sure it's easily viewable here. But this overall kind of strategy, do you think that would make it easy enough for you to find Dr. Folds? Because that was really our intent, was just to try and make it quick and easy for you to get that information once, you know, Sophia or Tomas has marked up that document, and then either Sophia or Tomas have processed it to the patient's chart.
No, perfect. Looks good.
Okay, that's great. So yeah, I think what we'll do is we'll just kind of finalize exactly which fields to use and how it'll pull in. And by the time our next session happens, you know, we'll be able to show the final workflow using actual VGH locations and everything. Right now, you'll notice we're still using St. Paul's. So I think that's why there are a little bit of issues right now with how the document pulls in. But yeah, if there are no other questions about that portion, I think we can move on.
Jesse?
Noting that it's almost, yes.
I can quickly demo kind of a mock-up of what it would look like, just really quick.
Sure. Yep. I think that's Dr. Folds. How are you for time? Do you have to leave like right at 9 to go? And
I'll just call the OR. Just hold on a sec, okay?
Okay, sure.
I'll share my screen really quick, Jesse.
Perfect. Thanks, Brian.
Let me know.
My patient's just asleep, so I have about 5 minutes until I have to head over.
Okay, I'll be really quick then.
No, don't be quick. No, I mean, let's do it properly, and we can always have another session. I don't want you to feel rushed.
For sure. It's a pretty quick demo piece. Are you able to see my screen right now with the red
box
I can. Here? Okay, so
yeah.
Basically, once you scan that document into the patient's chart or the clerk that does that, you would see it pull in here, which is I've highlighted it in yellow. It would have that note type of the vascular diagnostic report, and it would pull into that vascular surgery documentation, just so it's not lost in that provider documentation filter that you said. You know, it has all the providers documentation on that patient, so a little bit more available for you to see. And you can always, as Jesse mentioned, kind of click on that note type filter there, and it would kind of sort all these diagnostic reports together. And then you can also filter on the last updated so that it pulls to the top if you're looking for the most recent one. And then essentially what would happen once you kind of click on this note, just like left clicking on it, it would open a little kind of overview here on the right side of the screen that would show your scanned in image. I didn't mock it up at all because I'm not too sure what it looks like when you guys mock it up. But yeah,
That's really
what it would
good.
show.
So just a question there where it says free text note. Maybe you could change. I know that comes up often as a default. Would you be able to change that to maybe clinic ultrasound report? You know how like above it says admission history and physical, at least that is adding some value and some meaning, where yours just says free text note. I wonder if you could put there ultrasound report or something along that lines would just add some more information.
Yeah, so that's just the document, like the note template. I just kind of mocked this up really quickly and just use free text note because it's empty for me to put stuff in. You can put any note template name there. I'm not sure if the one that you just mentioned is available, but we can do some investigation if Jesse, if you can note that down.
Maybe vein mapping. Vein mapping would be.
Yeah, perfect.
Yeah,
yeah, that's great.
Yeah,
that's a good idea.
Okay, we'll double check if that's available or if you can just edit that completely freely. I'm not sure, so we'll take that back.
But otherwise, I really like it. That's great.
Yeah, no problem. I think that's all we wanted to show you is kind of that you can pull it up by clicking on the note once it's scanned in. I'll let you take back over, Jesse.
Thank you for that, Brian. Okay, so Dr. Foles, we're almost done. There's one very quick last portion we want to cover. So let me know if my screen is showing. You guys see?
Yeah, we can.
Perfect. So we were talking about this last time when I was showing some of the quick orders. Dr. Folds, you were saying like something like this resting finger pressure test is something you use so often. You were wondering if it could be on this quick orders page because initially it was not. So we were kind of looking and reviewing where we can add it. We were thinking on this outpatient quick orders tab, which is where you'd go for all of your quick orders. Just adding a new subfolder to this imaging and diagnostics kind of widget thing here and calling it possibly like vascular lab. So essentially you would just click the drop down and then it would open up and just show that resting finger pressure test order.
I think that's perfect.
Okay, that's great. Any other, like other than resting finger pressure test, is there any other things that you would want to see in there that would fall under the vascular labs category, or do you think that resting finger pressure test would be sufficient?
That would be all we would use at in the dialysis access clinic. So I would use it that. In fact, looking at your imaging and diagnostics tab, do you need to have all those things there? Like, for example, I would probably get rid of nuclear medicine unless they must be there. But just, you know, in the spirit of keeping things simple, it might be nice to get rid of the ones that we would never use.
Yeah, so I believe these are built out kind of for all physicians to look at that would be using that outpatient quick order. So I don't think we'd be able to remove
okay, no problem.
If that's okay. But yeah, but we could basically just add it to the bottom so you'd know where it is and you would just kind of like, you know, memorize where to go. You can also favorite the order as well. So there's a few different ways that you can kind of make it more visible. But it sounds like you agree with at least the placement of that order in a new subfolder called Vascular.
Yeah. It's a great idea. Thank you.
Okay, that's good. And we'll definitely take that back about removing subfolders and making it more user-friendly and just see if there are any options so we can revisit that next time. But for now, I think that's good that we at least know where to put it for the time being. Okay, and with that, that's basically it. That's all the material we want to cover. I noticed we're right at time now, so I'm glad that we were able to show all that. Thank you, Dr. Foles, for coming to this time. I know obviously you have a pretty busy morning, and we'll certainly take back all those items we discussed. And next time we meet, everything will be a little bit more finalized. So it'll be more of almost like a validation in a sense to go through everything. But I think we really have all the requirements we need. Like I said, I'll send you out those notes we jotted down for this custom auto text. So if you want to, you know, take a look at it and just kind of think it over more, and then we can revisit it again next time.
Okay. Well, again, thanks for all your work on this. It's really good progress you guys have made. Thank you.
Awesome. Thanks, Dr. Foltz. Glad to have you. Good luck on the case. Okay, so we did have a break set up here. How are you feeling, Sophia and Tomas? Do you guys want to take a quick 5-minute break, or do you just want to continue? It's really up to both of you.
I'm okay. Keep going.
Yeah, me too. Okay.
All right, let's do it. Okay, so this next portion is for you mostly, Sophia. So basically, we just took a look at some of those spreadsheets, your lovely spreadsheets that you utilize to kind of keep track of all these cases. So what we wanted to do is just, do some investigation in the system and see if we were able to at least make it so you didn't have to utilize all of these spreadsheets. I would say we were about 25% successful. So I think overall, your spreadsheets, the way that they contain information, it's a nice landing point where you have everything that you really need combined in one place. All this information, of course, will be in Cerner after go live, but it won't be as easily accessible all in one spreadsheet like this. So I think our main kind of suggestion is to keep using this spreadsheet for sure, your patient surgery list, to keep utilizing it after go live. I think there's certainly an option to reevaluate that once you get a bit more comfortable with the system, once you get used to using the various request lists, used to pulling reports from Cerner, that kind of thing. So there's certainly, I think eventually we'll be able to phase out the use of these types of spreadsheets, or at least consolidate it into maybe just one or something like that. But for the time being, this one, I think the main reason is because you have a combination of cases that have confirmed dates and ones that don't have confirmed dates yet. So right now in Cerner, there's not really an easy way to generate a list that has all of that. You basically can look at, a surgery request list, for example, that has future cases that don't have a date yet, and you can kind of sort that by procedure, and you can see some of the same information that you're keeping on your spreadsheet, but that list wouldn't show cases that have a confirmed OR date as well. You'd have to kind of go somewhere else to find that, and it's essentially not as user-friendly as your spreadsheet. So that's our recommendation for the patient surgery list. Certainly keep using it, but just kind of as you get more comfortable with the system and using request lists, we can look at maybe even paring down some of the information that you're capturing in this spreadsheet and just relying a little bit more on Cerner over time. But again, we want to make sure that you're not like losing out on this information. So we don't want to say like, all right, you must use Cerner, no more spreadsheets. I think just to keep using that spreadsheet. Same kind of thing with this patient procedure list and really this more specific CVC patient procedure list. It's kind of a similar issue where you're keeping track of cases that have a booked date and then also ones that don't have a booked date yet. And then there's also some information that you're keeping regarding like whether you've entered something to promise or not. So there's certainly a lot of fields, a lot of information you're capturing here that you can't really find in Cerner all in one place. So essentially for these three first ones, the patient procedure list, the patient procedure list for CVC specifically, and the patient surgery list, our recommendation is to keep using those three spreadsheets. Once again, I think what I just want you to keep in mind is certain places in Cerner where you can access that information. And as you're going through your education, as you're going through workbooks later and actually, learning these workflows in more detail, just kind of keep in mind that things like, the request list. So there's the ambulatory feature request list. When you use the request list, the appointment inquiry functionality in scheduling appointment book, there's also like confirmed appointment lists that you can find. You can filter by surgeon resources. So you can, look at all Dr. Fold's cases that have a confirmed date, that kind of thing. There's also Ambulatory Organizer where you can look at appointments by day. And then there's a variety of reports that you can pull. So just kind of keep that in mind that these are kind of places where you could find information that you capture in your spreadsheets. But again, kind of going into all these different places and trying to put all the information together is more time consuming than just having your spreadsheet, right? So I think that's really the conclusion, is just keep using your spreadsheets, but keep these functionalities in mind. And I think it'll be more of almost like a sustainment process. As you're getting used to the system, we can look at, an easy way to kind of replace that spreadsheet over time, maybe doing some more custom functionality for you or kind of exploring more options. But definitely for now with what's in the system, there's not something as user-friendly as your spreadsheet. So basically the recommendation is to continue with the spreadsheets. The one spreadsheet though, where there is a little bit of, I think we essentially you won't really have to maintain it anymore is this patient follow-up list. Because again, this one is a little bit more limited in the information you keep. And we do have these follow-up orders that will be used. And those follow-up orders will kind of go on one of your lists where you'll be able to track, and it'll actually have all this information that you need. So at least you're able to maintain one less spreadsheet, compared to the ones that you're currently maintaining, this patient follow-up list. And again, you'll have more opportunity in your kind of education and going through your workbooks to see how you would actually utilize that list in Cerner. So just keep that in mind, that this is the one that we can probably phase out right away, go live, but the other three, certainly keep those because they have a lot of kind of important information. I like how you kind of color coded the different positions here too. It's just a really nice, clean spreadsheet. So yeah, nice work using these. I think they're great. So yeah, keep using those, and then we can replace this one. Any questions about that kind of discussion, just going over these spreadsheets?
No, it makes me happy that I get to keep my spreadsheets for a little bit.
Yeah, so I think one thing that's important to keep in mind, is that the source of truth for everything is still Cerner. So that's why ideally we do want to eventually kind of phase out these spreadsheets and keep everything in Cerner. But right now there isn't really a good option to have all this information in somewhere where you can view it in Cerner. So that's kind of why we're just saying at first, utilize the spreadsheets. But we're going to certainly do some investigation and maybe, look at some custom report that we could even create for you that would pull in all this information. I think that's the ideal endpoint. So it's something that we're going to investigate, and probably something that we can revisit in the next session in April, if we can have something that could potentially kind of take over some more of these spreadsheets. But current state in the system, this is really the only one that can be fully replaced by Cerner. So we'll kind of just give you another update in the next session,
Okay.
TBD on these three other spreadsheets. But for now, just continue to use them. Sound good?
Sound good.
Okay, wonderful. So that is it for the spreadsheet discussion. So we're going to move into the nursing portion. I know our PD SMEs have not joined yet, but that's fine. So Irvin, are you ready to kind of just go over your forms gap analysis update?
Yeah, let's do it.
Wonderful. I will give you the screen.
Oh, can someone make me able to present? Thank you. Okay, just confirm you can see my screen.
Yep.
Okay, perfect. So I'm just going back to the group to confirm and sort of validate what the requests we took away from our previous session was and what it's going to look like in the system. So it's mainly three things. Number one is we've added, I'm going to enlarge this screen. Number one is we've added a new indication for the hemodialysis flow monitoring for post-fistulogram. In the mock-up here in the red here, I have decided to, I've asked the group, our team, where it's best placed, and just wondering how everyone feels about it being above thrombectomy here. It's not a really big deal. Okay, all right, so you're fine with this. Okay, so that's the first change. And the second one was the conditional logic responses. So depending on the access type that that you yourself will be choosing, if you have selected either of these four access types on the right-hand side, it will bring up these two pressures, DTA, so arterial pressure and venous pressure. On the other hand, if you somehow have selected the other two, central venous, left and right, it will bring up not just the pressures, but also the pump speed as well. So just bring that back to the group if there's anything else that we have missed. Otherwise, that's all I wanted to show the group. Does that look okay, Thomas?
I guess the pump speed is not going to show up. Is the pump?
Yeah, the pump speed, if you see the
it's going to show up as a full. Yeah, I see that. But in the fistulas or grafts, it won't show, but it shows as a delivered flow. Okay, that's yes. Fine too. Sure. Yeah. Okay, that's fine. Yeah.
Okay. Thank you. And that's it for me. Back to you, Jesse.
you, Irvin. So I think our Victoria. So did the PD SMEs confirm that they were coming for 9:15? Is that correct?
I did send them an email yesterday, yeah, letting them know to join us at 9:15, but they also have the full invite.
Right. Okay. I wonder, Maritza, maybe we can just do the nursing forms confirmation portion and then circle back to that line insertion once they join.
Yeah, totally. Can you make me a co-host so I can share my screen?
You look like you are a co-host.
Oh,
should be able to.
Perfect. Okay. Can you guys see my screen? It should just be the kind of like a Jira platform. It just has the VGH Renal VAC upload forms to FormFast.
Yep.
Perfect. Okay. So really just wanted to circle back with the group just to let you guys know that we've collected the forms here. I'm just going to scroll in a little bit. So these are the forms that we collected from you guys, and I'll bring them up individually just to confirm that we want to move forward to see if we can upload this into the FormFast application. So let me just scroll down. So there's the access surgery one, which we've already kind of talked through at length, so that will be available through FormFast. And then there's the cannulation sequence for new AV fistula. Sorry, bear with me as this loads.
I think that, Sophia, the access surgery, isn't that the one that the surgeons use for the nodes with the big arm? Isn't that called access surgery? That's not vein mapping. Was she showing the
Yeah, we had this one, we titled it access surgery. So we may have just saved it ourselves as access surgery. But I believe the form was likely the vein mapping form. So I believe it was a two-part form, predictors of upper extremities AVF, and then it was page 2 was your access surgery drawing.
Oh.
Apologize, I can't. Let me just see if I can download it real quick. Yeah, this one, can you see this one? This one, we'll try to get that uploaded into FormFast.
Yes, I see that. Yeah.
Yeah, and just to confirm, you will need to use this on paper,
Yes.
right?
Yeah.
Okay,
That's correct.
perfect. Yeah, good. And I'm just gonna go to this one. I think this one is
Yes.
cannulation sequence. Yeah, for new AV fistula with PC.
Yep.
So just the one page. Yeah. And then this one's cannulation sequence for new AV graft.
Yep.
Yep, good. So 2 pages, good. And this one's predictors of upper extremity. This was probably the first part, and then the second part is the diagram. But we'll get this one uploaded. And then this renal access, do you need this form uploaded at all?
This is the one that surgeons use that Thomas is talking about.
Okay, perfect. So we'll get that also uploaded. So that's all. So just wanted to confirm that that was all the forms that we're pushing forward to get uploaded into FormFast. So I do notice that some of our PD colleagues have joined, so we can.
Hold on, Maritza.
Yep.
Hey, Thomas, Sophia, what do you want us to name that vein mapping?
Vein
sheet?
mapping.
Just call it the vein mapping form?
Yeah, I guess so. I think earlier in the discussion with Dr. Falls, didn't
We'll call it.
Didn't it come up and we call it?
Oh, we said we would title it vein mapping when we upload it, but we can also name the form vein mapping form so that when you search for it in FormFast, you'll know it's that.
Sure. Yeah, sounds good.
Yeah, let's keep it the way it is. Yeah.
Yeah.
Okay.
Vein mapping. Thanks, Flo. Jesse, are you able to share your slide deck again?
Oh, sure. Yeah, I can pull it up.
Yeah, I see Chris is here from the PD area.
It should be coming up soon.
Great. Do you know if we're expecting any others from the PD clinic? To see Chris joining. I know it's just 9:15, just wondering if there's a few more people that are going to join.
Is working on it.
I'm sorry, yeah. Esther and Dan were also invited.
Okay.
And it's off today.
Sorry, did you say Dan was off today, Chris?
Yes, he is.
Oh, okay, thank you. Oh, perfect. I see Esther's here. Okay, great. We just wanted to invite our PD colleagues because we wanted to revisit the line insertion removal orders. So currently we understand that there is a little bit of coordination between the clinics, between Vascular Access and PD. Currently at VGH, the CVC removal does occur in your ICD procedure room, but can also occur in IR when there's no room. So we wanted to get an update as to what you guys had discussed locally from an operations perspective. I understand that you guys had a meeting recently together.
Okay, yes. So I will tell you what the process looks like right now. So the order for CVC removal will go to Sophia, and then Sophia will hand it to us so that we can talk to the doctors who will remove the CVC and to coordinate it with our scheduling. Then after we know all those data, we're going to send it back to Sophia for her to let the patient know and arrange all this pre-removal requirements. So that's how it works today.
Okay, because in the future, there, when this order is entered, there is that scheduling location field here. So if we put in different scheduling locations, it falls to the specific clerk's request list. So for example, if we put VGH Renal VA, it would fall to Sophia's request list and she can book. But it sounds like right now the thing that she doesn't know is the availability of provider resources.
Yes.
So can I ask, going forward, is there a standardized process, or are you guys going to follow the same current process of doing this?
For now, what I told you is what we are actually doing. And then also the other drawback of that is there's no regular doctors to do it. We are so dependent if there is a fellow rotating in our unit. If there's none, so there's the CVC removal will not happen.
So we have discussed it at the meeting, and decision was that we will continue with our current process.
Until Cerner comes in.
Well,
Yeah,
so with the Cerner coming in, we will still continue the same process.
Okay, so with Cerner, when Cerner is live, you guys will continue the same process. So I'm just going to talk it out in a Cerner way. Say there's a patient now that needs a CVC removal. A provider will place the CVC removal order that is shown on the screen. The scheduling location will still go to VGH Renal Vascular Access Clinic. So Sophia will see it. So when Sophia sees it on her list, I think what's going to need to happen in the future when Cerner is live is then there needs to be verbal communication or email or whatnot or phone between Sophia and PD side to get all that information that Chris was talking about. And then until that information is confirmed, Sophia, you can't book it until you get all that information. But then once you do get all that information, such as when the procedure room is available, the date and time, and who the provider and nurse is going to do this removal, then you can go back into Cerner and then schedule it according to what PD has given you. Does that sound about right?
Yeah, that sounds pretty clear.
So the only thing that's going to happen outside of Cerner is that communication back and forth, but you will still be the one physically booking the CVC removal appointment into Cerner.
Okay.
I have a question. What
Mhm.
if Sophia is on vacation? What will happen to the CVC removals?
Yeah.
That's a
And
good question.
Thomas will be looking at those then, I guess. Or yeah, operationally, either Thomas can look at the request list while Sophia's gone and keep track of it, or you guys don't schedule any at the time, or if you have a casual clerk that covers for you, then they can do it.
Actually, Flo, it was suggested, for example, around Christmas time, Thomas and I were both gone for about 2 or 3 weeks. And it was suggested that the referral then would go to the unit clerk, and then the unit clerk in hemo would pass it in to the PD side.
Oh, I see. And then so
So
Esther
then-
would then book it?
Yeah, either Esther or whoever is going to coordinate it on that side would do it.
This is
Oh.
Heather from scheduling. Can I just jump in for a second?
Sure.
I just wanted to ask Esther and Chris, I have the HD catheter removal appointment type on the list of PD appointments. So is it something that Esther would also need to schedule in the future? Because we do have 2 options. I can build it out for Esther to schedule as a PD appointment as well. Or the scenario that was just brought up with Sophia on vacation, Esther has the ability to open up the request list for the VA, the renal VA location. So she could go in there and monitor any requests for catheter removals while Sophia is away and schedule them on her behalf.
Yeah, that can happen, but the problem with that is we totally don't know the patients. If we need to do something prior to CVC removals, we are having a hard time following them up if they're in the community and all that stuff.
Hello, can I say something?
Yes. Vic.
Can you hear me?
Yeah, we can hear you, Vic.
Okay, sounds good. So Flo, what we discussed in the meeting is like, we have a current workflow is that Sophia is the one who is scheduling and booking all the appointments. And then she go over to the PD unit and discuss with the Dan regarding the appointment thing. And Dan would coordinate with the fellows and with the Chris or whoever available, and then book the appointment. Then their workflow again come back to the Sophia, then Sophia book an appointment. And again, the thing is all the procedure room is booked and the fellow and the RN is booked by the PD thing. And when the procedure has been done, the log run or CVC removal piece is again returned back to the Sophia, then Sophia enter it in the promise thing. So this is a current workflow as of now. And I was wondering, just in case if Sophia and Thomas is not here and the PD is taking the all thing, they are going to do the same way the Sophia does. Do you think it would be cross-cutting each other, or like they would be able to maintain a unidirectional workflow?
Wait, so let's back up a bit. So Sophia will get the order. She'll walk over and talk to Dan. Dan will make all the arrangements of who to book and when to book and give that information to Sophia. And then Sophia will then schedule it.
Yes.
With the patient.
Yes.
So that can still happen. And then I guess in the case of if Sophia's not around, then operationally you guys need to have another workflow in place for who's going to cover that workflow. I think it makes sense to have it shared between Sophie and Esther, because the IDC procedure room is already within the PD unit. So if Sophia's not around, then maybe those requests will have to go through Esther then, and Esther can book it. Like it almost seems like it's a shared space between PD and vascular. So both clerks should be able to schedule patients into it. With the only caveat that the way Sophia schedules it is based on what you guys are prescribing to her as the schedule.
Yeah, my question is like, just in case if Sophia is not available and Thomas is also not here,
yeah,
all the referral forms will be received by the Sophia in her, like, work queue monitor thing.
Yeah.
And if Sophia is missing, like, will that form will be pop up in the Esther as well?
No, so if
that is the thing that I want to know.
No, so if Sophia's away, then there needs to be communication that, hey, Esther, Sophia's away next week. Can you please monitor the vascular request list and look for any HD catheter removal orders and process those? Esther can see the request list as well.
Okay, and then Esther can book that in the PD, like their own procedure room and all that stuff. And like,
yeah.
And then she can also update a thing, like all the CVC removal procedure and charting in the same in the Cerner thing.
Sorry, could you repeat that question?
My question is like, who gonna update in the Cerner? Because as of now, Sophia is updating in the
update what?
Charting or like all the procedure thing like has been completed and this is the date and this is the follow-up appointment will be done. Because this thing is being done by Sophia as of now.
Yes. So if Sophia's not there and we're deciding that Esther is going to, or you're telling me that Esther will cover that workflow when Sophia's
I think maybe
there.
I wonder, sorry if I can jump in. I think what Vic means probably ultimately what Sophia does at the end to close the whole cycle is updating promise vascular access status, I think, with the line being removed. I think when it comes to Cerner, physician will make whoever removes the line will have to probably, instead of using paper chart, will have to go and do their little note, procedure note. The nurse who assists perhaps might also do some kind of a note that, patient was discharged, from the unit with stable vital signs, blah, blah, blah. And I think that the question is Esther gonna complete sort of the site? So on the Cerner, I don't know what else will be in Cerner, but I think this is the stuff that will be entered into Cerner. And then another question is promise, and I think that's probably Esther would ultimately go into promise and say, catheter was removed. Is that, Vic, what you meant, I think?
Yeah, that's what I was wondering. Like, I mean, scheduling and all the documentation is completed by the Sophia, but all the procedure is being done by the vascular access nurse and the fellow from the PD. So
yeah, so operationally, you guys have to decide as a program how you're going to handle the promise data when the procedure is done. So all the things that need to be done in Cerner will be completed by all the individuals, as Thomas just explained. The booking will be done by the clerks. The procedure notes will be done by the fellow who's removing it. The nurse may put in a narrative note as well as needed. But then when we go back to the promise part and the updates, then operationally, you guys have to decide who's going to do it in the place of Sophia being away. I mean, the same question goes for if Esther is away and you guys have to do a catheter removal on the PD side, you guys operationally have a workflow to follow to get that information updated as well. So I think you guys just have to figure out operationally how that's going to happen and who's going to do it and how that's going to be communicated.
Okay. So you mean Esther can even have an access to the vascular access workflow and she can update it even in the Cerner, even being a PD? I mean,
the only thing Esther will be updating in Cerner is the scheduling and the booking. She's not updating any documentation or notes or data. It's only the booking. So I'm not sure what updates in Cerner you're asking about. I think you're talking about PROMIS data.
Yeah, I mean, that also need to be done by the student because that will be missed then, because Sophia also does the same thing. She upload the thing in the promise.
So
And
I think that's,
yeah.
So that's
Yeah.
something you guys have to discuss operationally, if it's appropriate for Esther to also update the PROMIS data that this catheter was removed.
Mhm. All right. Then we are keeping the same workflow as it is as of now, right?
That was my understanding, yeah.
Yeah.
Yeah,
Same.
and I think for us, all we needed to know is like where the order is going to flow, because it would determine what we're going to build for you guys. And it does sound like the order will still go to the renal VA request list. But if Sophia's away, then the communication just needs to be given to Esther to monitor the renal VA request list
Yeah.
during that time that
that's correct.
Sophia's away. Yeah.
I just want
That's
to so I just want to confirm with the group that Sophia will be in collaboration with the PD information around like provider resources will book for both VA and PD catheter removals.
No.
Okay.
Only Sophia's only booking the HD catheter removals. She's
Okay.
only going to book it once she gets the information from Dan or whoever on the PD side, when to book it, which time, date, who is going to do the removal, and which nurse will be available. PD catheter removals is a whole other thing that is done by PD side. We're only talking about HD catheter removal.
No, I understand. I wasn't sure if that was a conversation topic that the group had locally in regards to what their workflow was going to be in the future. But we can look and discuss the PD side and at our PD related sessions. I just wasn't sure if it was all going to be for Sophia, but it sounds like Sophia will just manage the VA specific catheter removals in collaboration with Dan. And then in the event that she's away, Esther will just need to be notified and review the renal vascular access request list. So that's what I'm hearing from the group now. Is that correct?
Yep.
Okay. Okay, good. Thank you.
I have another question before we carry on. So we are talking about the regular CVC removals. There are some patients that are a little bit more complicated. For those who will, for example, that patients that we need to titrate their heparin or something like that, who will facilitate that if there's no Sophia and Thomas?
That's a good question.
How do you guys handle it now?
Well,
It's-
Thomas takes care of that portion of it, but and then there's also Karen, who's the yeah, I don't know who would do that if we're not here, Thomas.
I don't know who does that. I think the physicians and the pharmacists probably get heavily involved in that, I suspect.
So now I'm hearing that we are not just facilitating it, we're just taking over the whole process if we have those kind of patients. And also we need to document that somewhere on the Cerner or wherever.
So if this scenario happens right now though, Chris, who's been taking care of it?
Yes, so now there is another option for patients to go with this, right? There is such thing as surgical removal. So where that surgical removal comes into place?
No, there is currently no surgical removal.
Whatever the other removal is, aside from our removal here.
Correct. So it's a IR in radiology. Yes. So they send to radiology for the removal. Again, when I'm here, I coordinate it. When I'm not here, I believe between the physician and the pharmacist, they get involved in coordinating it in respect to anticoagulation. I mean, if it's a straightforward, we still have this parallel process when existing when the required resources are not available on the IDC side. So we do have that parallel second process when the referral still comes to vascular access clinic, and then we send it to radiology for removal, and that's it. So that can be done if the patient doesn't have any need for coordination of anticoagulation. If it's pretty straightforward, then
Oh, sorry.
That gets sent directly to radiology and by clerks, actually, the front desk, if neither Sophia or I are here. And if there is issue with anticoagulation with patient that needs to be coordinated and organized, then the physician and the pharmacist get involved in that.
Are you wondering about the scheduling of that surgical location in that process in Cerner?
Well, if it's gonna be done in IR, then the referral will go to IR, and that would be handled and booked by IR.
Yeah, that's right.
Yeah.
I just wasn't sure if Chris was asking for clarification about that. Okay.
What I'm asking is, what triggers us to send it to IR?
Probably what I'm hearing is it'll be determined by the physician if it's required to be removed in IR versus IDC procedure.
Because right now, what I'm hearing before is Dan already set a time frame like Monday and Wednesday only for CVC removals in our side here from 11 to 1 p.m. So I'm just asking if what triggers us to send it to IR? Is it because we need to remove the tube right away, or we don't know if the tube is actually can wait for a few more weeks so that we can provide the space? Or if there's no Sophia and Thomas, then if they urgently need the removal, we can just say that they can go directly to IR?
What happens now? Who makes that decision of where that catheter is removed?
So if Sophia is Thomas is not here, nobody makes the decision because the referral will just stay on the bin there outside the door of Sophia.
Then they'll just stay on the request list on Sophia's Cerner as well. If nobody's handling it, then they'll just stay in her request list.
So on that perspective, so we shouldn't need to involve Esther there then, because it can just actually stay on Sophia's bin until she comes back.
Well, that's why I'm saying operationally, you guys have to decide what you want to do. If you want it to all just stay in Sophia's request list and not be processed until she's back, or if you guys do plan to have coverage for Sophia, when she's away, then that's the discussion that needs to be had. Then you would involve Esther to monitor that request list for Sophia. It's almost like as if Esther would go monitor that bin while Sophia's away.
Okay.
I was just going to say, if there is provider consideration of needing the catheter to be removed in IR, there is a separate order set or power plan that they could enter in, which has scheduling related orders that will flow to the radiologist clerk's queue, and they can book the patient into IR.
And I think it comes down to if in the case Sophia or Thomas are away, and there was a patient needing an urgent CVC removal, and the doctor knows that Sophia and Thomas aren't here to deal with it, then I think their next step would be looking at
the power plan
in IR.
Yeah.
Does that sound right?
Yep.
Yeah. So it wouldn't be any different. So if they don't see Thomas there, they don't see Sophia there, the doors are closed, and they need an urgent CVC removal, then the hemodialysis physician will probably just send a requisition to IR for the removal then. Then it wouldn't go through Esther. But if there were those that weren't urgent and they're being put in Sophia's bin, then those are the ones where you guys have to decide operationally whether to leave them in the bin for Sophia to come back and handle them, or this is something we're going to involve Esther in to help cover.
Yeah, Flo, that makes sense.
Yeah, so I don't know
Yeah.
if you guys want to bring it back for more discussion around that. Otherwise, the way we build it is that those orders will fall into Sophia's request list for all those HD catheter removals. And then whatever you guys decide operationally, then we can teach you how to monitor and review those lists.
Okay.
It's a little bit of homework for you guys.
Sounds good to me.
Okay, thank you. I didn't have any more. I think, Jesse, I think we covered the forms fast. Irvin provided a forms analysis update. Yeah, I didn't really have any more to include in this nursing discussion. Were there any other questions from the group?
Okay, if there are no other questions, then I think all of our PD people, you guys are free.
Thanks, Chris and Esther, for joining.
Yeah, thank you for the discussion. I guess turning it back to you, Tomas and Sophia. So that really was all the content we actually had for today. We were able to get through quite a bit in our previous 2 sessions. So it kind of took some of the weight off this session. Any questions, Tomas and Sophia, any just general questions you guys have about anything we covered either today or just anything we've covered in the previous sessions as well?
No, not from me.
Good to hear. Sophia, how are you feeling?
Overwhelmed. This is a lot. This is a lot to take in. So
it is, and I mean, we totally understand that. You know, these sessions, there's a lot of content in these sessions, and it's all very new. There's probably some fear and anxiety surrounding the fact that you know, it's a totally new system, a new way of documenting and interacting with your work. So I think you know, it's a lot to take in. You'll have some time over the next, you know, month and a half or so to just let everything sink in, incubate. We're going to be having another session in April. I think it's like about mid-April or so where we'll come back together. I think by that point, we'll have a lot more of the build kind of completed. We're also going to be spending some time just taking a closer look at what our St. Paul's users are really doing in the system and just doing a thorough review to make sure that we have everything covered. So we might bring a few things back in April to you guys then as well. And we'll also kind of utilize that as somewhat of a validation session to just kind of go through the functionality, hopefully using the actual VGH locations. I know so far we've basically been demoing and showing information using St. Paul's stuff in the system because that's what's built out. But we'll probably have some more updated build in VGH to kind of show you guys. And we'll recap on some of the stuff that we discussed, especially with Dr. Folds earlier. But once again, I just want to remind you that these sessions are really like the first round, just to kind of get exposure and to see what we need to work on to kind of allow you guys to be able to continue doing your work, hopefully improve aspects of it. Obviously, the spreadsheets, you'll keep using those, Sophia, so there'll be some comfort in the old ways as well. But again, really the purpose of these sessions is just to introduce the system to you guys. You'll have so much opportunity in the kind of learning program and curriculum to really go in the system yourself and actually practice. I know that's something none of you have done. So yeah, you'll have a lot more opportunity to do that. There's going to be, you know, a lot of classes you'll be in, workbooks, lots of resources that'll be given to you that literally break it down step by step to show you how to do all the functionality. So don't worry too much about that. It'll come with time. Again, these sessions are happening earlier just for us to get the requirements. And yeah, there'll certainly be some more discussion about promise. I know that's kind of a big thing as well with these workflows. So we'll revisit that more next session. But yeah, I just wanted to really emphasize that there's no pressure at this point. You don't need to like remember all of this. Again, we've taken thorough notes. We've even taken some recordings of these sessions so we can look at options of maybe sharing some of that with you guys down the road as well. But yeah, I just wanted to make sure that you don't feel any like anxiety really. We'll revisit in that session in April, and then there'll be plenty more learning opportunities as well. So again, I know that was a little bit of a final rant here, but if there's no other questions, I think we can essentially end this session like an hour and 15 minutes early. I just wanted to really thank you guys for being so engaged in these sessions. I know you guys are like such a dynamic duo together, so it's really helpful just to have your input. You guys work so closely together. That's something that we want to preserve when Cerner goes live as well, obviously. And it sounds like you guys just have a really good flow together. So I think that'll work out well. So if there are no other questions, we can certainly end the session early. If you guys have any other concerns or thoughts or anything you want to add, feel free to just email me directly. I can bring it back to the group. We can discuss. But if not, we'll see you again later in April. And we're all going to be quite busy with the whole children's go live. So you probably won't hear much from us for the next month or so. But once again, yeah, just feel free to reach out if there's any questions or anything.
I have 2 questions at the end. So I guess one, our opportunities to practice actually in some kind of a sandbox environment, whatever practice environment, is that going to happen after validation or before validation?
That's a good question. So that will most likely happen after validation. I think
I'm sorry, I'm just, you know, sometimes it's one thing to going through it like if you just in your head kind of thing, you know what I mean? And it's very different when you start working it and you realize, oh, I didn't think about that. You know, like it's difficult to keep these steps, imagining it, something system that you've never seen. I never seen it. I don't know. I would imagine when this system was built in, you know, first of all, for the renal program in St. Paul's, there was a little bit more like on the ground, like kind of going step by steps, and the experts had a chance to actually really see it and think about every single step that they will be actually doing, and that will raise a lot of questions that you don't think about when you're just going on a very imaginary theoretical level. I think having practiced before I validate it, because once I validate it, I will be told it's too late now.
You're stuck with it, right?
Yes.
Yeah, I hear you. And I think one thing that we could certainly consider, and maybe I'm speaking too soon in saying this, so Maritza, just shut me down if you think that's fair. But I was thinking, I mean, we could potentially like invite you guys over to St. Paul's at some point, just so you could kind of see, you know, what they're doing in the system. They do have access to some train domains. There's like this X domain, we call it, where, like you said, it's kind of like a playground where you can go and mess around. But even like potentially shadowing some of them just doing their workflows in Cerner. I'm not sure if that might be something, Tomas or Sophia, you guys think could be helpful, just so you could kind of see it in action and potentially even have an opportunity to play around in one of those boxes, like you call it.
Yeah, totally, Jesse. I think it's definitely something that we can look into. I can speak with Wayne to arrange something if you are both willing to come over to St. Paul's one day just to shadow.
Absolutely, I want to come. I want to see how it's done. Yeah.
Yeah, because I think in previous meetings, Wayne has offered that up as a suggestion to his, you know, the VGH colleagues. So I'm definitely going to hold him to his word. But yeah, I think you're right. Like definitely seeing it live is a little bit different than what we go through in demos and these sessions, and then hands-on keys. That experience is very valuable. So why don't I follow up with Wayne and we could try to set something up in the next little while.
Perfect. Thank you.
Good. Now, on the similar related topic is, I guess we'll be seeing how it's actually used, right, in real life. But we will see in respect to our obviously vascular access clinic. We will see the setup that the build that is they use for them, right? So we won't have a chance, I guess. I mean, we'll have to think about how we made some minor changes to the build, probably not very substantial, but it would be nice to see it, practice it actually with our build that is being designed for us, because ultimately we will not be using St. Paul's build, we'll be using VGH build.
Yeah, you make a good point, Thomas, because so the only hesitation I have for you guys to go see what like Nikki and Colleen are doing is that their workflow is so different from what you guys do. And the way they run their clinic is so different from what you guys do as well. Yeah. It's almost night and day. So really, you guys shadowing them you'll only really be looking at the function of Cerner, not the workflows. Because the way they're going to order and the way they're going to book and the way they register is completely different from what you guys are going to be doing and what you guys are currently doing.
Yep.
So
that is my concern too. Yes, that's like to see the workflows actually practice on our workflows, so we can see for ourselves possibly some gaps or things that might not work for us. Right?
Yeah, totally. So I almost want to caution that. I mean, I wouldn't stop you guys from going to shadow and take a look at it either, but at the same time, I don't want it to kind of not cloud your mind of how things work, because it might confuse you more, because then you're going to come back thinking, oh, this is how we should be ordering it, but then that's not actually how we built it for you, or that's not the workflow. So if we actually had the time to build everything that is for VGH setup, like you said, I almost feel like it would be more worthwhile if we spent more time actually going through the validation, like step by step from end to end, going through every single click and showing you what could happen in each scenario, and then looking at it wholesomely that way. Because now you're really seeing it from the workflow and perspective of VGH and not how St. Paul's is doing it. Because really the only benefit you'll see is just the function of Cerner, not how you're going to use the system.
Yeah, I agree. I agree with you, Flavius. I think that's actually that's what I'm really more looking at, really seeing it, as you said, click by click, seeing what's going to be done with us, for us, how we are going to utilize it.
Totally. So I almost feel like if we can focus on the validation piece, click by click, spend more time showing you, and then validating it. And I totally agree with your concern about after validating and then going back to be like, oh crap, I thought about something else we should have done. Like that's always going to happen. And then depending on the severity of it, we always have, processes where we can escalate things to make modifications or changes before go live. Obviously, we try not to do that as much as possible. But then after validation, then the part of it is once you start going into boot camps and workflow reviews and things like that, you will have access to the training domain. And that's when you're going to be able to go in and really practice and use the system and see what it's like. And even then, a lot of times things come up where you're going to notice something got missed or whatnot. So I think that would be inevitable. But if we can get it as close as possible during the validation and really go through the workflow from beginning to end that way to show you guys what it would look like from every role between you and Sophia and the surgeons, I think that might help better than you guys going to shadow at St. Paul's. I don't know, just my thought. Yeah,
no, I agree.
No, those are all very valid points. So we can still try to arrange something for you to come to St. Paul's to see just the functionality of Cerner. And then from a validation session perspective, like maybe for our team, we'll just have to plan time out. So in our agenda to go click by click through the workflows and show what is built out for VGH and how that aligns with your workflow. So we'll just have to make time for that in our upcoming sessions.
Okay.
Thank you. One last question. When do you know when is the go live date for us planned at this point? Do you know by any chance?
It's a
no determined date, but Flo, if you hear anything different.
I heard like November or something.
Maybe this year.
That's what I heard as well. I heard November 2022 is the kind of tentative, and nothing is certainly set in stone, but that's the grapevine date.
Okay.
Yeah, and then just to echo what Flo said, I mean, if there are build design aspects that are validated, things can still be changed and modified post go live as well. So just don't think that it's set in stone, it's forever. Changes can always be made. Yeah.
Okay, great. Good to hear. That's on my part. That's it for me.
Okay, Sophia, any other closing comments, or you feeling great now?
Yeah, pretty good.
I'll take pretty good. That's
that's
good enough. Okay, guys. Well, once again, thank you so much. If you have any more questions, feel free to reach out to us. We can give you back the rest of that time now and end the session over an hour early.
All right.
Okay, great.
Thank you very much.
Thank you.
Thank you, guys.
Yeah, thanks everyone. Bye.
Bye.